cohort, about 1/4 of them who initially relapse after the transplant, but we find that they become sensitized to treatments that didn't work before. So where before they had to have super high doses of steroids to keep the disease under control, they could get by with a much lower dose. So the transplant probably does something to reset the immune system. Maybe we haven't fully removed every bad clone that was causing the autoimmune process, but we have made the system quieten down somewhat, such that if we reintroduce like steroids, it becomes easier to control. So yeah, there's a possibility after a transplant that patients may flare. The likelihood of flaring has to do with how advanced the disease was beforehand, as well as amongst MS even there's a continuum, because there's some patients that have one flare every 3 years, then there's some who are flaring 3 or 4 times a year. So in these really active patients, perhaps they have a higher risk of flaring after. But most of the time, it's the patients that have got the most inflammatory active disease that are likely to respond to the high-dose immunosuppression and go into remission.
Yeah. And another question is any risk from this treatment, because there is high dose of chemo and other medicines involved? Is any risk that in 5 years or 10 years it can develop another disease or cancer? Or...
Yes, so certainly. So there's I mentioned the late risk of secondary cancers is present as long as you've given anyone chemotherapy. A lot of it has to do with how many rounds of chemo. It's difficult to estimate for autoimmune disease because compared to the number of patients who have been transplanted for conditions like multiple myeloma or leukemia, you have a large number of patients, and when you follow them up, it has been reported to be as low as 1% to even as high as 9 to 10%, depending on the regimen that you use for the transplant, whether it contained radiation or not. How many cycles of chemo they had before they came for the transplant also made a difference. Yeah. So when it comes to autoimmune cohort of patients who don't have chemotherapy prior to the transplant, it's their one and only exposure, as it were. The risk is hard to estimate, but based on the last 20 years of follow-up of all the various regimens that are used around the world, it's probably in the region of 1 to 3%. I'm not sure whether those patients who had radiation early on in the earlier cohorts in America, they've not reported what happens to them now. It's been about 15 years since. I won't be surprised if 1 or 2 of them has a malignancy because of their exposure to total body irradiation. It's just the risk inherent in being exposed to these types of regimens. And it's one of the reasons why we don't take all comers all comers with mild forms of MS, for instance, who think that they don't want to be on any kind of medication. This is a quick fix, right? But we may actually incur a late toxicity. So that's why the disease needs to be severe enough, but not so advanced as to become that the patient is already paralyzed. So that balance that we need to keep. Yeah. We have to be ethical in not subjecting patients to a treatment that may incur a late toxicity.
Yeah. So in patients like that have been healthy for the most of their lives and live healthy, so this is lower risk of...
That's right. So it has to do with also how many rounds of exposure you have.
Yeah. Usually with the non-ablative one, so that's the less...
Yes, that's correct.
Yeah. Thank you very much.
Anyone else? Oh, sorry. We'll just... No, you... I'll get you next.
How long do you have to be on Ty-Sabri before you can have the treatment?
Okay, so this is a little bit of a difficult situation. In Northwestern, they recommend that the patients are off the medication for a full 6 months. But then again, there's some patients who stop the drug for 4 months and flare. So this is my take on it. They need to be off it for at least 3 months. The reason is that the drug has a very short half-life, but it has a biological effect that lasts for about 5 or 6 months. Ty-Sabri is interesting in that because of the way it works, it also prevents the stem cells from homing into the bone marrow. So theoretically, when they're on Ty-Sabri, they would actually mobilize stem cells better because there'll be a higher proportion of stem cells floating around the blood. So I'm happy to harvest them when they have not been too far away from the last Ty-Sabri dose because of this. But I'm concerned theoretically that if you do a transplant after that, shortly after the last dose of Ty-Sabri, maybe the stem cells won't find their way to the bone marrow so easily and grow. So for that theoretical reason, I recommend at least 3 months of the drug before the actual transplant.
And are you equipped to cope with the John Cunningham virus there at the hospital?
Which virus?
JC virus.
JC.
Oh, okay. So JC virus is uncommon, extremely uncommon. I've not seen one for the longest time.
Because some hospitals will and some won't, you know.
Right. So if the JC virus titer is there, it doesn't exclude them from being on the transplant. It doesn't completely exclude them from being recruited. A lot of it has to do with how long an exposure to immunosuppression you have. So, like for instance, if you've been on Tisari for many years, then there's a higher risk of getting PML.
10 months.
Yeah, compared to those who have not been on Tisari for as long a duration of time. In a situation of transplant, it's not been tested. It is not an exclusion criteria for being recruited for a transplant.
Thank you.
Do you want to go?
I just wanted you to explain the treatment duration and also at the end of it, how long you would need to stay in Singapore before you can leave.
So we recommend, okay, so the actual first day of mobilization, we count that as the start of the treatment. It just takes 10 days before we start to harvest the stem cells, and then maybe for 2 or 3 days after that. So that the first phase is maybe 14 days. Then there has to be a break of at least 2 weeks to rest. And then actual admission for the transplant just lasts for about 2 or 3 weeks. But after that, we advise patients to remain in Singapore for between 3 to 4 weeks for monitoring purposes. The blood counts need to recover fully. When they're discharged from the hospital, they may not have perfect blood counts. We may discharge them even when the platelets are in the 20s, because the risk of bleeding is low, and the platelets will take a bit longer to recover. So that's one. But I'm monitoring them for CMV. So CMV is a virus that most of us have been exposed to by the time we're adolescents. So in Singapore, it's extremely high seroprevalence of CMV. So when we do the transplant, there's a risk that the CMV virus may wake up from the latent phase and go in and start to actively divide in the blood. So we need to do a blood test to monitor for CMV virus in its active form, and if necessary, institute anti-CMV treatment before to eradicate the virus from the blood. So the reason for keeping them in Singapore is to monitor the blood test and to do the CMV. And when we're sure that they've not reactivated, then they can go home. Yeah.
Anybody else? Yeah.
Sorry, so how much is the treatment in Singapore?
We
Can I ask another question? So when you do that 2 weeks during the treatment, do you stay at the hospital or is it at a hotel?
It's in the break between the two?
Yeah.
No, in fact, the whole of the mobilization period is done outside of the hospital.
Okay.
So it's they don't have to stay. They just come to the Raffles Cancer Center. They receive 1 day of chemotherapy,
Yeah.
and then they go home and they continue to inject themselves with GCSF for the next 5 to 6 days before we start collecting on day 10.
Okay, so in a hotel or...
Yeah, or an apartment close by.
Okay,
Yeah.
and yeah, my next thing was how... can I ask one question? When we were talking about to this lady about cancer, and that's a 1 to 3%.
Right.
Yeah, so it's 1 to 3%, and how long do you think this treatment lasts? That's what we all like. How long, first of all, how long does this treatment, is it 5 to 10
Like the
years?
effect?
How long will you stay in remission from
Yes,
MS?
yes.
I think that if you're going to relapse, you most likely will do so in the first 1 or 2 years, because
Yeah.
that's how the curve is. It's steepest in the initial 1 year, and then it plateaus off. So if you're not going to flare in the first 1 or 2 years, the likelihood is you probably won't flare anymore.
That's really good news for me.
Yeah. So the thing is, that has been the experience. So the patients that have done well are the ones that came still in an inflammatory phase, and those that we have followed up for more than 10. So my first patient is 2002. So after the transplant, she never had a flare, and she's been well since. So on the whole, the patient that doesn't flare in the first 1 or 2 years, they're unlikely to flare.
Okay,
Yeah.
And so, so how much is the treatment?
Right now, I think we are
110 to 120,000 Sing.
Singapore dollars, yeah.
About 100,000 US, less than 100,000.
About 100,000 US.
So now we're about, I think the Aussie dollar and the Singapore dollar is about par now.
Yep.
So yeah, so it's about 110,
And
120.
that's not include, it's not include accommodation.
No.
That's
It
just
includes the
straight-
inpatient stay for the 3 weeks of the actual transplant phase when you're staying.
Yeah.
It includes the hospitalization ward charge. But for everything else that's outside the hospital, no.
So, and also too, so getting back to that later, so if you haven't had any chemotherapy before the treatment, you do have a lower risk.
Yes, I think it has to do with how much you've been exposed, and it's difficult to time. But to give you an example, so autologous transplants were being done for breast cancer in the 80s, right? And then it was in vogue for a period of time, and then they realized that there were all these late secondary cancers that were coming out, like about 5 years after the transplant. So it's fallen out of favor. So it stopped doing autologous transplants for breast cancer. But these breast cancer patients had also received radiotherapy, they also received multiple cycles of chemotherapy before this. But there's no doubt in my mind that the high-dose therapy contributed to them getting a secondary leukemia, because most other breast cancer patients don't get that complication. Yeah.
All right, thank you.
The chemo that you receive when you have this treatment, is it as harsh as what the chemo you receive when you have cancer?
No. Yeah, it's not.
What degree less?
It really depends on the regimen they use. So we're using fludarabine and cyclophosphamide. It is a regimen that is unique for us in MS. We don't use it otherwise at that dose for treating chronic lymphocytic leukemia. So it's slightly different. It's just that we know that the combination is a safe one because the drugs do not adversely antagonize one another, and they can be used safely.
So it's a lot less than the other.
It's a lot less, yeah.
And safer.
Safer.
Thank you.
When you're having the chemotherapy, can you leave the hospital, can you? Isn't there a chance?
So for phase one you leave the hospital because it's
Yeah.
just 1 day. But during the actual transplant, we keep you in the hospital because we want to monitor you, and it needs to be 24 hours.
There's a chance of infection too, because your immune system's not up to scratch.
Yes. So when you're in the transplant ward, you will be in a isolated room with just you and one caregiver that can stay with you. And the transplant ward has a HEPA filter to reduce the likelihood of fungal infections, and a positive pressure so that the air doesn't mix with the general population. Yeah.
And how long would you have to have given up smoking before?
Oh, we don't have a fixed time, but as a doctor, I should say that the right answer is you should quit any time because it's good. It's good for you to not smoke.
Like if you went for the treatment, would they say?
Oh, we don't stipulate, but you're gonna get withdrawal symptoms if you don't quit before you come in, and we keep you in the ward for. You definitely cannot smoke in the ward. if that's your question, yeah. So
Okay, thank you.
I've got a couple of questions that came through online.
sure.
What supportive medications do you give during the treatment, such as steroids or Mesna, PPIs? What other medications? People are looking to compare different facilities and what they give.
So when they get cyclophosphamide, they'll get Mesna, for sure. They also get prophylactic antibiotics, usually ciprofloxacin or levofloxacin, acyclovir to prevent a viral infection, cotrimoxazole to prevent PCP. So acyclovir patients are on for at least 1 year after the transplant to prevent shingles, and they take PCP prevention for at least 6 months.
Brilliant.
Yeah.
Yeah.
So how long after you do the transplant is the high risk time? Like 1 month or 3 months or 6 months? Is a higher risk you can get an infection?
Okay.
Something can go wrong.
So in general, the highest risk will be when your white blood cell count is low. So that's when you have the immediate risk of a bacterial infection. So that's why we keep the patients in hospital during that period for the first 2 to 3 weeks after the transplant. Thereafter, it's more a risk of viral infections. And this remains because you have done a lymphodepletion, because your lymphocytes are your first line of defense against viruses. And that's why you have risk of things like getting shingles. So patients take that antiviral medicine for 1 year to ameliorate that risk. They still have a risk of having common cold and things like that. So for the first few months, we recommend that they avoid crowded places. Just be conscious of the fact that you have contacts that are sick that they should stay away. We actually recommend vaccination against influenza for their family members, so that when they go back to their home, they don't get flu from their relatives. Patients themselves will eventually get vaccinated. We don't do it immediately after the transplant because they would not be able to produce the antibodies. After all, we have depleted their B cells. So even if we give them a vaccine, they won't be able to develop the antibodies. So about 6 months after the transplant, we recommend revaccination against influenza. And then we also give anti-pneumonia vaccines at certain fixed time points after the transplant, and then yearly influenza vaccine thereafter.
So, when is that carried out by the specialists back in their country?
Yes, so if they've gone back to their home country, then we would give a recommendation for their specialists to administer the influenza vaccine and the pneumococcal vaccine back home.
I just went to my GP.
And what about travel, like plane travel and things like that? Getting from Singapore back to, say, Australia?
Yeah, so that's why we keep them at least for a couple of weeks, and then when they're on the plane, a mask, and it's about as good as we can. Yeah. Short of a private jet.
Yeah. If we all go as a group. Yeah.
So, does the side effects when you are, because my husband is going to take interferon from tomorrow, so the side effects that he might have, does it fail as like a failed therapy? Does it count?
Some patients are so intolerant of interferon that they have to stop it. Like they get suicidal on it. Then obviously these patients cannot remain on interferon. Then most of the time they would be tried on another agent thereafter. Yeah.
But does it count as a failed disease modification drug, and you qualify for the?
I see. So because I don't have this is not done within a protocol anymore, right? So it's not a study. So we have to do things on a case-by-case basis.
Yeah.
So like in the health situation, the health economic situation in different countries vary. So in Singapore, patients pay for their treatments out of pocket.
Yeah.
So therefore, in the past, if they were intolerant to interferon and then they became eligible because nobody's going to be able to afford the thousands of dollars per month to pay for Tisabri unless they have insurance. So this makes it kind of like a case-by-case basis. It's just an inaccessibility to available therapy rather than the failure of available therapy. And I've also had some patients consult me from New Zealand, and their health system is such that even for them to qualify for interferon, they need to be bad enough, but if they're too bad, they fall off. So then you have patients who actually would, in ordinary circumstances, need another therapy, but they have to wait another few more months before they qualify or they get funding. So that becomes more like on a case-by-case basis, individualized application or transplant to them, not because there's no other available therapy, but because they just can't get access to it.
Yeah. And another thing is, so for example, what about these patients that want to use the first-time treatment, the stem cell transplant? Is there any chance of not going through the medication? Because I researched it and there are so many side effects. So
I wouldn't more because, as I said, for ethical reasons, because you are subjecting a patient to a risk of however low. There's still a 1% risk of something bad happening. And you may say it's 1 in 100, but what if that 1 is you?
yeah.
You know? So we have to make sure that the disease is severe enough to warrant the treatment that we're giving. And when MS has just been diagnosed within the last 1 or 2 months, you really don't know how it's going to do.
Yeah.
He could very well be one of those patients that do really well in the long term. And
what about
people
you had symptoms before, like attacks before the diagnosis, like a year before?
But that's basically how MS is diagnosed, unfortunately. You need to have 2 separate events. And some of those you may have dismissed. Maybe he had a little bit of numbness in his hand and he just sort of ignored it and went away. There's really no way to know whether at the time that was a manifestation, just from thrust of him wanting to get MS.
Yeah. Okay.
So my sister has MS, and she we just freshly diagnosed in the last year, and she's still pretty good, like has no symptoms. And but in the now looking back in the last 10 years, there's things that we've noticed. what, I mean, as she was saying that, like, if she's still now, like, you're saying if she's been diagnosed for 10 years, is it good to have the treatment now, or do we wait if she gets worse?
So I know, so because of the data that I showed you from Northwestern, it suggests that after 10 years, right? But that is 10 years of diagnosis of MS, not on a suspicion of symptoms.
The diagnosis is 10.
That's right. Yeah. And even then, my question would then be, why is it okay at 9 years, 9 and 11 months, but not at 10 years and 1 month? So that's a problem with having data that is dichotomous when you're dealing with a condition that is continuous. But as you have to define limits. The same thing with the EDSS, right? Because we have to define limits of why is it 6 or 6.5 rather than.
So what do you take? Like, I know some countries.
I take up to 6.5.
They have to be 6.5
and below.
And below.
Yeah.
And what about if it's under 1?
Then,
like, say one sister's got it, she's
correct. So my question then is, does she really need it? Because there's always this risk that you're subjecting someone to a treatment that has potential for mortality and late effects like a loss of fertility and cancers and so on. And you may overtreat someone that actually doesn't need it. So that's the question that we have. So I mean.
But then you're saying the earlier that you get it,
yes.
the result.
So that's the balance. So that's the balance that we have to strike, because at the end of the day, as a physician, I'm ethically obliged to do no harm, right? So I'm ethically obliged as a doctor to do no harm. So I cannot offer a treatment that I think may potentially harm someone unless I think that it's really going to help them. So as I said, it's not absolute, because if I'm dealing with something which I know is going to make them much worse, they're going to get much worse if I don't do it, then the risk becomes a justifiable one. So likewise, like when I talked about treating cancer, I knew that if I know that if I don't treat them, I will lose them in 6 months, then even if the risk is 10%, I will take it, because it is a risk worth taking to save someone's life. In a situation like MS, where you can live for 20 years and be alive, and I give you a treatment that, even though it's a low risk, even if it's less than 1%, that someone may die during the treatment, then then you have to make sure that the patient really needs it before you subject them to that risk.
So basically what you're saying is that you look
severe
at
enough.
case-by-case situation.
Exactly. So you need to be severe enough, but at the same time not disabled. So that's the difference, right? You can have MS that is active, but you still have an EDSS of like 3, because you're having flares. So the severity is marked by the fact that despite being on DMDs, you have 2 flares or more in a year, or 3 flares in the last 24 months. I take that as a sort of a gauge of how severe or active the MS is. Or for those who are getting into the secondary progressive phase, it becomes a bit harder to define. It has to do with how long they've been in SPMS before we take them for transplant. But those who are going to be 7.5, no, because the likelihood is I may be subjecting them to an unnecessary risk with hardly any benefit. Yeah.
Caitlin? Oh.
Thank you. During the outpatient period, if there were to be problems, would we just come back to Raffles?
That's right, yeah.
Just be admitted?
Yes.
Or,
It depends. So sometimes the problem is that you just feel nauseous.
yeah.
And just give you some antiemetics and you're okay. You have a fever, for sure you have to be admitted. I've never actually had a patient that had a fever from the 1-day cyclophosphamide. The dose that we use, the blood counts maybe fall to 3. So your normal counts are 4 and above, right? So maybe they fall to 2 to 3, and then they bounce up again. So the risk of infections is actually very low.
So you were at risk when you're in the second stage.
Yeah.
And then you'll be risk anyway.
That's right.
Yeah.
Just about the EDSS score. I mean, is there an objective sort of measurement, or is it something that's quite subjective?
I think you've looked at how it's charted. To be honest, it's very much dependent on the person doing it. But it's the best tool that we have that allows some degree of comparison between studies. So, a neurologist scoring the EDSS is what we have to go by. That's about as good as it gets. I know that it's not perfect, but as I said,
So when you were talking about I suppose, the extent of the disease, and say, for example, with feeling as though you're going from 3 to 4, so you're under the 6.5, is that the sort of thing you're saying, well, now I'm starting to get to a level where you know, I really should be seriously looking at this.
That's right. So there's a definite worsening despite being on therapy.
But getting to a 1 or 2, obviously, maybe not bad enough, but you're starting to get to a level of disability. 3, 4, and 5, those sort of areas is where you start.
So, like in relapsing remitting MS, because of the way the disease is, there are times when you have a flare, and at the height of the flare, or the peak of the flare, you may end up very disabled. Maybe if you were to score the EDS at that point, which is inaccurate, it would be 7.5. But then after a course of steroids and with physiotherapy, a month later, they're back to being at their baseline. So the way to look at is actually the baseline, rather than at the point where they're at their worst, because that would not be an accurate way to assess how bad the EDSS is.
Yeah.
Doctor, who does the risk assessment, and where is that done in comparison to the treatment?
Risk assessment meaning?
You mean the application, assessing your application?
No, I assess the eligibility for patients myself.
Right, but
Right.
how long before the actual treatment do you do this?
Oh, I see. So usually when the patients get in contact with us,
Yep.
we would go through the records and the MRIs or whatever they have, and preferably a report from the neurologist to say how they have been doing on therapy and what has happened. So with that, we determine whether the disease might potentially benefit from a transplant.
So you do the risk assessment without actually seeing the patient?
At that point, we're looking at whether or not there's a chance to improve the patients neurologically with the transplant, in essence. Yeah. So, and then in terms of risk, in terms of how they are physically to tolerate the transplant, we look at the medical history, and we also would recommend that they do some basic blood tests, and when they're coming for transplant, before they come, in part to save on costs, to have sometimes things like the echocardiogram, their lung function tests done in their home country before they come, and then they send the reports to us first, so that we know, because if, for instance, they had a poor heart, with a poor ejection fraction, like less than 40%, then at that point we wouldn't accept them into the transplant anyway, and that would save them having to come all the way to only to be turned back. Yeah.
Any other questions? Yeah.
The Lemtrada, is it okay to be on Lemtrada and then do the HSCT?
So, to be honest, I don't know, because the drug's only recently been approved. My familiarity with Campath for so many years is in treatment of CLL, and is used in allogenic transplants as well. Now, the problem with alemtuzumab is it actually suppresses the immune system a great deal, and in fact, the infectious disease doctors call it liquid AIDS, because that's what you're doing. You're sort of paralyzing the whole T cell portion of the immune system, and they have the risk of infections just like someone who has got HIV. That's what you're doing. Okay. Now, at the dose that they're giving for Campath for MS, I'm sure it's dosed lower, such that the risk is less, but the immune effects can last for 6 months or more. The immunosuppressive effects. So, because FDA has only just approved Lemtrada for MS, I'm not sure what we should do with these patients if they come for transplant. Maybe they need to be off the drug for at least 6 months.
But it's not an exclusionary factor at this point?
At this point. My question now is, would they have a higher risk of having a secondary autoimmune disease? And the answer is possibly. Just based on the fact that when we used it for transplants in patients with not just MS, but even for SLE, there was an unacceptably higher risk of having a secondary autoimmune condition, like very bad refractory ITP, or something quite easy to treat like Graves' disease.
So would you say that if you are looking at HSCT in the next couple of years, you want to consider very carefully before you jump on Lemtrada as a band-aid until you get to HSCT?
Yes. I have some reservations about, I mean, to be honest, just from having used Campath over the years for a different indication, I always hesitate, even before I introduce it to patients who are post allogenic transplant who develop graft-versus-host disease. Because once we give it, the patients will end up with other secondary problems, so lots of infections. So, but of course, that is a different cohort of patients. These are patients that are highly immunosuppressed. They're post-allogenic transplant. In the MS population that's otherwise well, maybe it won't behave the same way.
Do you find with the Melania that you get that infection in them as well? Was it the same as
Not as high. Yeah.
So other treatments as well, you have to be careful. Or any other treatment, you have to be careful if you are considering this.
One of the reasons is that this is a shifting, this will be a shifting sort of, as we keep adding new agents, we have to adjust accordingly. So like for instance, before Tesabri was approved, it was never really an issue of having to be off drug for so long. Patients could be on interferon to the very day they come into hospital. But with Tesabri, we say, well, we want to at least wait for 3 months. So it's just based on how the drug works. The biological effect of Campaf is also lasts for 1 year, which is why the way it's approved now is you get a few doses and then you're off it for 12 months, right? And then hopefully with that you do okay. Yeah.
So we've only got like 10 minutes left, so make sure you do ask your questions just down the back there.
If you are accepted, what's the waiting list time?
We don't really have a waiting list right now.
Oh, don't you?
Yeah.
Everyone's so excited. Yeah?
Just had a query. When you were saying before that generally it's from 10 years of diagnosis.
Right.
Hypothetically, I read a story in the MS In Touch magazine where there was a lady that had relapsed and been for about 15 years, did really, really well, more or less had feeling symptoms, and then suddenly went downhill from there. Also, I've also studied that said that it's better if you're under 40, your chances are better. So hypothetically, I got diagnosed 2 years ago, relapsing remitting on modulinia. If I was to go 15 years and I'm okay, and then I go backwards, have I got any chance of doing something like this because then I'm in my 50s and have been diagnosed over 10 years?
I wouldn't be able to know for sure. As I said, in that analysis where they look at patients more than 10 years and less than 10 years, it's just like a post hoc analysis. It's not like a prospective follow-up of these patients. They just found that those who had MS for a longer duration didn't do as well. So the question is, how long is too long? Yeah, I don't know. And the thing is, for that patient that you mentioned, who got worse suddenly after 15 years, was it a flare or did she enter into secondary progressive
She
MS?
went from, she went quite severe. She had flare-up, and then from that flare-up...
She just never got better?
Never got better, and went from, like I said, 15 years of almost nothing to within 3 or 4 months was wheelchair-bound.
So in a situation like this, I wonder whether at that point she had some new triggering element so sometimes the flare is triggered by being sick, for instance. So it's well known, right? When you have a fever, your symptoms become more pronounced. It may not necessarily amount to a flare, but we've also seen patients with a bad flu or a bad infection who had a flare that was triggered after that, and that may have set off a chain of events. Yeah.
Would you want to have 2 failed DMDs to accept a patient?
It's individualized, and for the reason that I explained, it has to do with also access. So I don't close the door on someone who's only failed one because they don't have access to another, simply because of the situation in the country they're from, or because they, like in Singapore, they have to pay out of pocket and they just cannot afford to pay for daily Gilenya or for monthly Tesabri.
Or if they're JC positive or something.
JC, yeah.
And down the back?
Just on an incredibly practical viewpoint, you mentioned the cost is about 100,000 odd for the hospital treatment. What do you need to budget for in terms of the outside hospital accommodation?
Jenny,
I know it's hell's a piece of string type question, but I'm sure you can answer it better than I can.
Accommodation in Singapore, it depends on what you're looking for. If you're looking for like 1 or 2 months stay in Singapore, but perhaps you can stay in a service apartment. And the cost would range from 4,000 per month to about 6,000, depending for like 1-bedroom apartment or 2-bedrooms apartments. Some of you might come with a caregiver, so you might need a 2-bedroom apartment.
So
Singapore dollars.
So about $6,000 a month. That's what you need to budget for.
That is for 2-bedroom apartment.
Thanks.
Any other question?
Is there any other cost to that?
Any other costs? What about ICU admission?
Yeah, so
or-
in the event that they have a bad complication, the patients may need ICU stay, and that is not included in the estimate that we give that would cover majority of patients, but not the small number or with the unlikely event of ending up in the ICU.
So if you get infections, if you get sick, it costs you more.
Yes, but the 110 should cover most, like maybe 90% of patients.
That's with ISO, yeah?
I beg your
With
pardon?
isolation.
Yes, with isolation, yeah.
Sorry, this is Felix.
Isolation.
Will every patient lose their hair?
Sorry?
Does every patient lose their hair?
Oh yeah, they do. It's after even just that 2 grams per square meter of cyclophosphamide, so the first mobilization dose, by the time we start the harvest, they're already dropping their hair. So by the time they reach that 2-week rest period, most of them are checking out wigs and scarves. Yeah, no worries.
So after the transplant, you shouldn't have to take any MS medications. Is that?
On the whole, no, yeah. So most of them are able to come off the medicines completely, unless they have a new flare. Yeah.
Now, some different facilities have a personal recommendation if the patient flares as to what they recommend for a top-up, whether it be rituximab or cyclophosphamide. Do you have a personal recommendation, or do they just do that in consultation with their haematologist back home?
A neurologist or a hematologist back home. So sometimes you would try just a pulse of methylprednisolone, sometimes with rituximab, or just a pulse of cyclophosphamide might be good enough.
Okay.
Have you had many people come? Have you treatments at this hospital, or is it just starting now?
So it's just starting now.
Just starting now.
Yeah. So I've moved from Singapore General Hospital where I was, and then and now I'm in Raffles. So it's just starting out in Raffles. Well,
But there are Australians there now.
Well, we came over with a bunch of, I took the team over, in essence, and also we've done 7 transplants now since we started in January for other indications and 1 for MS. They're all discharged within 2 to 3 weeks, yeah. Yeah.
And how many have you overseen at your previous location?
Hundreds.
Mm-hmm.
I mean, because I was the director of so I wasn't just treating MS patients, the bulk of my work is still malignancy, yeah. So when I was there, I've done hundreds of transplants, yeah.
So are you just treating MS patients now?
No, I'm not.
No.
Yeah, so up to this point, so now it's May, right? So we've done 7 transplants since the beginning of the year, mainly for malignancies, 1 for MS, yeah.
Yeah, and do you use the same treatment as Dr. Berg in Chicago?
No, it's different. So for MS, as I highlighted, my protocol is different. And when I came back to Singapore, I elected to continue the program because of the risk of CMV. And I did discuss with him. So in fact, when I had a grant from the government to do the transplants, Richard Bird was the advisor on that grant. So you know, he didn't say that we needed to change the protocol. And the underlying principle, as I said, is the same, which is that of a relatively well-tolerated chemotherapy regimen that is mainly lymphodepleting and non-myeloablating.
Some people have noticed that compared to other facilities that use high-dose steroids throughout the entire transplant, that you guys don't. Is there a rationale behind that, or?
I would give steroids just around the time when engraftment is expected, because of the risk of engraftment syndrome.
Mm-hmm.
Some centers would use steroids with GCSF because they don't use cyclophosphamide for mobilization. And so there's really no necessity to throw in the steroids if you've already given some sort of immunosuppressive at that point. During the transplant per se, steroids will be introduced just before anticipated engraftment and for a few days after, just to reduce the risk of engraftment syndrome.
And you spoke about prophylactic medications, antibiotics, and acyclovir.
So they get acyclovir, they get antibiotics, and they get antifungal when the blood counts are low to prevent an infection.
So do you send them, say they get back on the plane to Australia, send them home with a couple of weeks' worth until they can get to their own doctor?
That's right. Yeah.
Okay.
So they definitely need to be on acyclovir for a whole year.
Yes.
Yeah.
I agree.
Sorry, I asked a lot of questions. So what if you come home, because I'm from South Australia, and the doctors there don't want you to mention HSCT, they don't approve it, and maybe they don't want to help afterwards, so...
Oh, there's some in every state. We've found haematologists in every state who will take you on.
So actually what we recommend is, I won't let a patient leave until I'm sure there's someone to continue their care. It's a part of the responsibility I have to the patient to make sure that there's someone back home whom I can discharge them to.
Yeah. Because we have 2 GPs and 4 neurologists that my husband's been through, and none of them
But they're the wrong.
do anything.
Yeah, but most of the people coming back from overseas have a haematologist overseeing them, and I definitely have a haematologist name in every state in Australia that you can see who will take on the MS patients, HSCT patients. So I can help you with some names, but it's not uncommon for the neurologist not to want to see you again. But there are also, I have names of neurologists who will see you, but it may not be the ones that you're used to.
Doesn't matter.
Yeah.
But that means the access has to be private in that setting, right? They can't do it through the health system.
Generally private, but you know, it's not ongoing. I only see mine every 6 months now, so there's a small cost to be attributed in the first year or so, but it's not excessive compared to what you've paid for your transplant, and for your well-being, it's a small cost, I think. Do you pay up front or in?
Okay, so because we use that CD34 selection column, which is a disposable one patient use, so we have to have some assurance that you're coming before we order that column. Yeah, so that's an initial payment, and then when we get admitted, the hospital requires that you pay the sum before they allow you to be admitted. Yeah.
Once you have the treatment, would you need to do it again, or can you do it again?
I've never had to do it again, and neither has anyone in Chicago.
Yeah, they have.
Huh?
They've just done a patient for a second time. Very young, a young girl.
So I mean, it will really be not on a study. It will be something like.
But if you need to do it, I know some treatments say, I don't know where it is, but if you do it once, you can't do it again. I know the one in Russia, if you do it, you can do it again, but can you do yours again?
Oh, she's talking about myeloablative versus. Some doctors say they could repeat non-myelio, but you can't repeat the beam.
I wouldn't repeat the beam option again, for sure. Theoretically, you could get another round of cyclophosphamide without any additive toxicity to organs. Of course, you would significantly increase your risk of infection in the second transplant if it has been quite close to the first. So that's something to consider.
So you use the beam treatment?
No, I don't.
Oh, okay.
Yeah. So we're using just 2 drugs, fludarabine and cyclophosphamide.
So is it myeloablative?
It's non-myeloablative.
Okay, that's because.
That's the less toxic option.
Okay, even with the non-myeloablative one, like Russia or America, it still is better. Less toxic than what Russia. And Dr. Richard
Well, in Russia, they're using beam, right?
No.
They're using
Cy plus Ritux.
Plus rituximab. It's an interesting combination, actually.
I think it works well.
I think they're using beam for their own local
patients. For some of the Russian patients, that they can follow up, but they can't follow up the international ones, so they're doing non. Yeah.
That's a curious question. Is there a follow-up that you have to go back to Singapore for?
Ideally, I would like to see them again at 6 months, just to make sure that we can do some of the vaccines and get them going. Otherwise, they may forget, and if we don't see them, we may forget. So that's the main reason. And also, it would be good to assess them neurologically at 6 months. But we understand there's a cost involved in flying. So if there's someone that can take over that function back home, then we may not need to. But even in Chicago, patients used to try and fly in at least once in 6 months, so that they could have an EDSS scored by the same neurologist that did it initially. Yeah.
Any other questions? There is some rumours going around that Singapore General will consider doing beam for severe cases. Is that something that you would consider? Are you firmly in the non-myelio camp?
I think that using beam for maybe the secondary progressive patients, potentially, but if you just look at the lymphodepleting Cy-ATG, even though Richard says that it's not something that he would offer to secondary progressive patients, when he took those patients on a compassionate basis, they were stabilized. And if that was the aim of doing the transplant for secondary progressive MS just to halt further worsening, then it seems that a lymphoablating regimen may be good enough. Using beam for secondary progressive MS is not something which I would consider. I would be surprised if you tell me that do that because they...
It was patient reported, so...
Yeah, so the thing is, because of my role as still a visiting consultant in SGH, I'm still consulted for all the autoimmune patients that go for transplant. And we've not discussed this about changing the regimen to beam. So yeah.
And another question I got via email yesterday was, what other autoimmune conditions will you consider treating with HSCT?
Lupus is one, but that's lupus patients are difficult because they often have many organs that are already affected by lupus. But definitely in severe lupus, it's something we'll consider. Other neurological conditions like myasthenia gravis, CIDP, we will offer. And we've also done for systemic sclerosis. And this is one of those things where the rheumatologist doesn't disagree because there's really no good treatment for systemic sclerosis. So they actually have quite a low threshold to refer them for transplant.
And what about SPS or severe Crohn's?
Severe Crohn's? Okay, so Crohn's is very rare in Asia. When I've not done one personally, although I had one come to me seeking treatment. I think it would have to be individualized. If the patients have a very high immunosuppressive burden, like they've been on steroids forever, and now they're receiving etanercept, Humira, and all these things, they tend to have a much higher risk of infections with active fistula. So we have to make sure that they're in the best physical state before we can do it. But you will still use a more lympho-depleting regimen, cytoxin and ATG.
Right. Yeah. And stiff person syndrome?
I've never done that before.
Okay.
Yeah.
Yeah.
What about multiple muscle atrophy?
I must say I've neither looked at the literature about that, neither have I done it before, so it's difficult for me to comment. Yeah.
Okay, any last chance questions? All good? Okay, well thank you for coming everyone, and thank you to the team from Raffles for coming to speak to us today.